Hello, everybody. This is going to be a lecture on Chapter 8, Motor Speech Disorders. You'll find it to be quite different from any of the chapters we have gone through before. You're, at this point, done with pathways. I know you'll be glad to hear that, but don't forget them because we'll continue to integrate the information that you learn on disorders with what you have from the past. So do take the time. We're not going to be throwing more on, but take the time to consolidate anything that you need to, so that you'll be able to address clinical problems as they come up. All right, so let me go ahead and share a screen and make it big. There we go. This is the title from the chapter, Clinical Speech Syndromes of the Motor Systems. I have sort of retitled it into something that's a little more conventional. We call this group of disorders that are dealt with in Chapter 8 motor speech disorders. That would be the common name for this group. And it breaks down basically into the dysarthrias and apraxia of speech. So two overarching categories. Dysarthrias has a number of subcategories, as you can see: flaccid dysarthria, spastic dysarthria, ataxic, hypokinetic, hyperkinetic, and mixed dysarthria that occurs when you have two or more of the types that are listed above mixed together. And you get that in several different things, but the most common ones and the ones that have been studied the most would be amyotrophic lateral sclerosis, also referred to usually as ALS, and also multiple sclerosis, referred to as MS. The information that's going to be presented here comes from what I would call a germinal study. That is, it's a classic study that everybody knows about, and it sort of got us started in our way of categorizing these disorders into the categories that you saw on the previous slide. And I just put this here, and I also posted the article itself. You can read it if you like to. I'm not going to test you on it, but I wanted you to at least have access to the information about how we got these patterns of ratings, basically, that you're going to see in the next few slides. Where did they come from? They came from Mayo Clinic, actually, where they have access to lots and lots of patients with somewhat unusual disorders. So it was kind of easy for them to put this study together. Of course, it was a lot of work. But what they did was to take 30 patients in each of 7 discrete neurological groups. Now, how'd they get those groups? They got them from the neurology staff. The neurologists, made neurological diagnoses, and then they studied the speech of the 30 patients within each one of those groups. And they used a 7-point rating scale, which is very commonly used in clinical speech language pathology. I use it. A lot of SPLs use a 7-point rating scale for a variety of different things. And the ratings were 38 different ones. They had 38 different ratings that they felt could be important in differentiating among these neurological diagnostic groups in terms of their speech pattern. There were things like breathiness, vocal harshness, consonantal imprecision, hypernasality, low pitch, low volume, short phrases, et cetera, et cetera. And if you want to look at them in more detail, of course, refer to the study. But what you're going to see as we go through each of the different types of dysarthrias is some of those ratings sort of came to the top in prominence among the 3 different SLPs who rated each of the 38 dimensions for each patient in each of the 7 different categories. So that's how they went. And then they did statistics on it and tried to determine which of the rating categories differentiated the patients the most accurately. So that is a classic study, and good to be aware of it. All right, so now what we're going to do is we're going to go through 6 types of dysarthria, or 7 types, I think, maybe, and look at the ratings that most differentiated that category from the others. So looking first at flaccid dysarthria. Now, in terms of the neurology, what's going on in flaccid dysarthria is that everybody has what's called bulbar palsy. The neurologist diagnosed it. It simply means palsy is weakness, and it simply means that one of the motor nuclei that you've learned now in chapters 7 and before too was directly involved, which meant that they would have lower motor neuron involvement. And you should associate that by now with that term flaccidity. They have lower motor neuron involvement. Not necessarily all of the cranial nerves would be involved, but some of them. Whichever one was hit by the lesion, actually. And so it's important to realize as we start going through this process of looking at the characteristics of these different types of dysarthria, that these rating categories that we're looking at represent averages of a group of 30 people. Not every patient within the group would have all of these features, and they may not be ranked in the same way. In other words, for some patients, hypernasality is the worst thing when they get called a flaccid, when they get labeled with flaccid dysarthria. For others, it might be imprecise consonants. For others, it may be breathiness, but this is the average. So we carry these averages with us as we try to assess patients and make diagnostic categorizations of their dysarthria. So hypernasality, imprecise consonants, breathiness of voice, and nasal emission. I think you know what each one of those is. Maybe not nasal emission. Nasal emission is when you actually hear the air coming through the nose because their velopharyngeal function is so poor. Hypernasality is more of a voice quality, and it relates to velopharyngeal function, of course, too, but nasal emission is a kind of a worse expression of that same velopharyngeal incompetence. And by the way, let me just say, I have put an example, a video recorded example of each of these types of dysarthria in the module, and most of them have a little lecture with them. And I really like these recordings because they do relate it to the neurology, and they give good quality recordings. They offer good quality recordings of each of the types of dysarthria. And as you listen to the brief lecture, and they are short, as you listen to the brief lecture, you'll recognize everything, I believe, because we've been through it all. So he's just going to be, expressing or explaining the dysarthrias in light of the pathways and nuclei and so forth that you are aware of already. So I think that will be very helpful. Okay, looking at the second category, spastic dysarthria, these people have upper motor neuron lesions. So they have spasticity in their body, and this is how it sounds when it comes out in speech, is again, imprecise consonants. This time, instead of breathy voice quality, they have harsh voice quality or strangled voice quality, where they actually sound like they're trying to phonate while being strangled. They also have hypernasality, and they have a slow labored quality, which you would associate with spastic movement of any kind. If you watch a patient who's got spastic dysarthria move an upper extremity, the movement's going to be slow. It's going to be weak, and it's going to be slow. So this is an expression in speech of spasticity. Ataxic dysarthria involves cerebellar damage, or is caused by cerebellar damage. And it also, they all have kind of imprecise consonants. So it involves imprecise consonants, irregular articulatory breakdown. And listen to the tapes, because you'll hear that. If you just ask them to repeat a simple syllable like pa 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 pa, I'm doing it fairly evenly, I hope, but they're going to be more like pa 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 pa, irregular articulatory breakdown. Prolonged phonemes, prolonged intervals, that would be the quiet time between words and phonemes, and also a slow rate. Characteristics of hypokinetic dysarthria are monopitch, monoloudness, reduced stress, short rushes of speech, reduced articulatory precision due to reduced range of motion, and harsh or breathy voice quality. Now, hypokinetic dysarthria, I think you'd already associate it with Parkinson's disease, and that would be overwhelmingly the most frequent disease that causes a hypokinetic dysarthria. As you listen to the videotapes for each one of these, have these lists in front of you and try to discern those characteristics, but also do keep in mind that each patient is going to be a little bit different, because the list you're looking at right now represents an average ranking of the top ratings. That means the worst. The worst quality was mono pitch, mono loudness, and reduced stress in this group, in other words. But you're not going to see the same ranking or even all of the same categories in each and every patient. There are going to be individual differences. But yeah, do keep it in front of you. That'll be helpful. Okay, hypokinetic. Now we're going to go to hyperkinetic dysarthrias. Those people had choreas, as in Huntington's chorea, dystonias, and dyskinesias. And they did do subsequent research where they tried to break those down more and show the differences between them. But as a category, they demonstrated irregular articulatory breakdown and vowel distortion. And I think that's the first category that you've seen, vowel distortion. Irregular prolongations of vowels and silent periods. Harsh voice with irregular pitch and loudness variation. First time we've seen that in these rankings. Frequently caused by prolonged use of antipsychotic drugs and levodopa. So these problems can have an acute onset on people who have medication. That's a very frequent cause of it. Sometimes taking them off the medication completely takes care of their motor speech problem, and sometimes it improves it, and sometimes it doesn't help, unfortunately. You've probably heard of ALS, or amyotrophic lateral sclerosis, before I mentioned it today. These are the characteristics of that. Again, imprecise consonants, hypernasality, harsh voice, which can sometimes be so harsh that it's strangled. There it is down at the bottom of the list. A slow rate, monopitch, and short phrases. And now, these are the characteristics of mixed dysarthria in multiple sclerosis. Oh, I should say something about, I'm sorry, I missed a point here on ALS. Why is it mixed? Because it involves both upper and lower motor neurons. That's where the damage is. It's not up in the cortex. Their cognition is fine, but clear up until the point of passing away, which typically is due to aspiration, because they cannot manage their air. They can't swallow finally. It gets that bad, and they can't protect their airway. Some people may choose to go to have a tracheostomy and be on a ventilator, in which case they can prolong their life quite a bit, maybe years. Some people many people actually elect not to do that, and they will then succumb to aspiration pneumonia typically, and also just inability to breathe adequately, because respiratory muscles are affected too. Okay, so that's mixed. In other words, it has characteristics of flaccid dysarthria and spastic dysarthria. Now, in multiple sclerosis attacks the neurologic system anywhere, and it comes and goes. So an attack can involve vision. You can have a hemianopia, or a partial visual field loss, and then it kind of gets a little better. And you can have then a tingling in the left hand, and gets a little better. And so it comes and goes. It has periods of what they call exacerbations, which are getting worse, and remissions, getting better. Each time there's probably a little bit of brain damage, though, that occurs with this disease, which involves a breakdown of myelin. So they over time they get worse. There's a lot of medical research on MS, and some people do quite well for many, many years. Other people progress rather quickly. Now, the reason I put this in red is twofold. First of all, I did want you to know that if you put damage all over here and there, it comes and goes, it's going to be a mixed dysarthria if they have a dysarthria, which they almost inevitably will have eventually, because it's going to involve at times upper motor neurons, lower motor neurons, cerebellum, and it's it's going to, basal ganglia, it can be anywhere and everywhere. So I wanted you to be aware of the category that and also the fact that Darley, Aronson, and Brown in their 1969 study did not include patients with multiple sclerosis. They did look at them later, but this is from a 10-year-old study that investigated 168 people with multiple sclerosis, and it's kind of a long list. So I just put it down because as read, because I don't expect you to memorize it. I think it's the most challenging category to diagnose because it does come in so many forms, owing to the fact that the brain can be involved with multiple sclerosis in so many different locations. And obviously that's going to express itself differently across different people. But you can take a look at this list and be aware. And I believe I do have a patient with multiple sclerosis, so you can listen to that very brief tape. I think it's only 5 minutes, and see which of these seem to characterize that particular patient. Okay, then we get to a different category. We're moving away from the dysarthrias into apraxia of speech, or sometimes called verbal apraxia. And this is due to a lesion in Broca's area, Brodmann's area 44, 45 in the dominant cerebral hemisphere. And it has some distinctive features. First of all, you will see visible and audible articulatory groping. That's a search for the right position to put the articulators in. There will be variable and inconsistent articulatory errors. And that, in particular, that one is helpful, extremely helpful in making the diagnosis and differentiating apraxia of speech from any of the dysarthrias, because the dysarthrias tend toward consistency, whereas the apraxia of speech tend toward inconsistency. Whereas they may be able to say a word one attempt, fine, or not, the next attempt is going to be different. In fact, when we get to the testing procedure, you'll see that one of the tests is simply to have them repeat a word 3 times. With a dysarthric, and especially any of the dysarthrias except the hyperkinetic, not as much. With the dysarthrias, they will be consistent across those 3 attempts at the word because they're simply expressing a weakness or spasticity or an incoordination or something. But the apraxic is struggling to find the articulatory position that is correct each and every time, and it will come out differently across 3 attempts. So that's why that's part of the test, and I'll point that out again. There will be a prominence of substitutions, additions, repetitions, and prolongations over distortions. Most of the dysarthrias, we see distortions. In apraxia of speech, as they grope for the right articulatory position, often, very often, they pick another position that is an acceptable position in the language that they speak. And so it comes out as a phoneme, but not the right one. Whereas in a dysarthria, because of the muscular involvement, the strength and so forth, when they are off, it's more likely a distortion because they aren't hitting it hard enough or quite precisely enough. But again, there's consistency. And then the final thing is that there is dysprosody. They have pauses, false starts, self-corrections, and overall rate is slower. They also tend to have short phrases. Okay, now let's look at how we go about assessing motor speech disorders. First of all, we always, when you get into your seminars and later classes, we'll go into a lot of detail on this, but we look at the background information, and background information would include all the medical information that's relevant, the neurologic diagnosis, etc. We also look at their language and cognition, and we also look at deglutition. The reason for that is because you can't really set up a treatment plan for motor speech. Let's say that's the focus. You may clearly everybody may understand that the patient's there because of a dysarthria, for example. And that will be your focus. But you can't set up a treatment plan if you don't know if the patient can remember instructions for compensations or whatever it might be. So you need to know about language and cognition. You need to know how you can communicate with them effectively in terms of your use of language, and how accurate you can expect their language to be when they're communicating back. We also assess deglutition, even if the patient has not been directly referred to us for deglutition, because deglutition, swallowing, is within our scope of practice. And if we were to leave it out and the patient experienced a complication as a result of deglutition problems or dysphagia, we would be liable, because we should have known that in that patient there was a high risk for them having dysphagia. Dysarthria and dysphagia coexist very, very often. I don't want to say usually, but probably if there's somebody has a dysarthria, they at least have a mild dysphagia. And the only exception to that rule of evaluating swallowing is if the patient is not currently on an oral diet and is instead tube fed. In that case, we would call the physician to get an order to swallow, do the swallowing evaluation, because it may be in fact dangerous to give them anything by mouth, even to try to assess their swallowing. But if they're already eating, then we would screen at least their swallowing. Okay, now as far as the diagnosis and assessment of the motor speech goes, we're going to analyze the relevant background information. We'll do an oral facial examination. We'll do a motor speech examination, which we're going to look at in some detail in the next few slides. We'll do, as I said, a brief language and cognitive evaluation or screening, and we'll do a brief swallowing evaluation or screening. So those 5 things would constitute the entire evaluation, and it would all be written up. It would be in your form, whether it's an electronic medical record with a checklist or whatever it is. It's all going to be included. All right, a little more on the background analysis. We would like to identify the etiology, and what are the likely etiologies for AOS, apraxia of speech? Well, probably a stroke is the most likely one in the cerebrum in that area, or that includes that area. Likely etiologies for dysarthria could be brainstem stroke, certainly. They could be peripheral nerve lesions that come from injuries to the nerve itself. Sometimes we have patients whose recurrent laryngeal nerve is nicked in a thyroid surgery, for example. Sometimes people in automobile accidents have neck injuries that involve the vagus nerve, more so than other nerves because it's so long, so it's just plain more vulnerable. Multiple sclerosis and ALS are obviously possible etiologies. Tumors would be etiologies. Traumatic brain injury, that's an etiology, especially for spastic dysarthria, because traumatic brain injury usually damages motor systems in both sides of the brain, involving upper motor neurons, and then you have spasticity, including spastic dysarthria. Medical complications we want to identify as well. And a complication would be something that reduces the potential of the patient to participate vigorously in rehab. For example, let us say that the patient is very elderly and has multiple medical problems that have resulted in them basically being bedbound. They're not going to be able to participate vigorously in rehab as well. So that would be a complication. Sometimes we see patients who are on dialysis, and they tend to be much weaker and have more ups and downs as they go between their dialysis sessions. So those are situations that we pay attention to. We don't pay attention to every medical condition. For example, maybe somebody had a appendectomy 20 years ago. It's not going to affect their ability to participate in rehab and to benefit from it at this point. So I'm only looking, as I look through the medical chart, for anything that affects ability to participate vigorously in rehab. We also do want to determine the prior level of function, and that's very important, because sometimes people will have a new onset of a stroke, for example, or let's take the stroke. But but they had something going on before they ever had the stroke that affected their communication. For example, you'll see many people who have a stroke, but they also had Parkinson's disease before they had the stroke. So we need to know exactly how they were functioning in speech, language, cognition, and swallowing before the onset of the illness that is bringing them to us at this moment. And the options for figuring that out would be, well, sometimes you can ask the patient and they are able to give you a good history. Sometimes you can ask the significant other or others and they can give you a history. Sometimes if patients are coming from a nursing home, for example, they'll come with some medical records already that describe their functional abilities in the main areas of living, including communication, eating and swallowing, toileting, ambulation, etc. So if you cannot determine that, you can't really do much of a good treatment plan. And that does happen occasionally. I've seen a few patients who, for example, were homeless and found on the street, and nobody is aware of a relative, and the patient cannot inform as to how they were doing before. So that happens once in a while, but not very often. Typically, we can get that information if we try hard enough, and we need to. What I usually do is I complete the evaluation first, and then I call if the relative is not there, and then I call the relative, because at that point I'm able to give them some information about what we did, what we found, and ask them some things that I need to know, and one of those most important would be the prior level of function. All right, these are some standardized tools for assessing motor speech. Sorry, I'm jumping around. The one is the Mayo Clinic motor speech evaluation, and that's the one I'm going to give you parts of today and show you. There are some other standardized ones: French aid, dysarthria evaluation or assessment, the quick assessment for apraxia of speech, and the quick assessment for dysarthria. You can look them up if you want to, and people do use them. We've got them in the clinic. But Mayo Clinic motor speech evaluation is very, very commonly used. Why? Well, because it came from that germinal study. That's essentially how they studied their patients and rated them on a 7-point scale in those 38 categories after eliciting this kind of speech samples you're going to see on these next several slides. So typically you start out with imitation, vowels. Have them say ah, and you're listening to the voice quality. You're listening to the loudness, you're listening to the pitch, you're listening to the duration. Then we have them do pa-pa-pas, ta-ta-tas, and ka-ka-kas. We ask them always to imitate them without rhythm. So in other words, I'll say, here's what I'd like you to say, pa-pa-pa-pa-pa-pa-pa-pa-pa-pa-pa-pa. And sometimes they'll start and say pa-pa-pa, 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 but you have to stop them and not let them do that, because it's kind of an unconscious strategy if they're having trouble with rhythm, as in ataxic dysarthria, to break it down a little bit and give you pa-pa, 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 or pa-pa-pa, pa-pa-pa, makes it easier for them. But we want to hear it without rhythm. Pa-pa-pa-pa-pa-pa-pa-pa-pa-pa-pa. We're listening to rate, we're listening to precision, we're listening to accuracy. We're listening to, of course, voice quality and resonance. Then we do the same thing with ta-ta-tas, and then same thing with ka-ka-kas. And then we have them put them together, pa-ta-ka. And that may be the first time you begin to see the characteristics of apraxia of speech in somebody who has apraxia of speech. They might have gotten through what you're doing so far, but when you have them vary the articulatory position in a smooth way, and again, so we don't let them say pa-ta-ka, pataka, pataka, pataka. They have to say pataka, 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 pataka. It's very difficult for somebody, even with a relatively mild apraxia, to not start to show you the irregular articulatory breakdown and dysprosody that's characteristic of apraxia. Then we have them do simple CBC syllable sampling across the consonantal spectrum. So let me jump ahead for one moment to the next slide so you can see what those would be. Okay, so we start with mom, Bob, Pete, Bib, and you're listening for all those characteristics. And then we want to be aware of the phonetic demand. So by that, I mean some phonemes are easier to produce than others. Here, they started with mom. That's the easiest. Well, there's one easier actually. a glide. A glide is easier. So you'll have people who can imitate vowels, but as soon as you get consonants in there, they start to break down. They can have a dysarthria or an apraxia of speech, either one. Apraxia of speech probably more likely to show problems like what I'm trying to describe now. But if they can get any consonants at all, it would be a glide. Then the nasals come in, then the stops, then finally you progress through this till you get to affricates. That little continuum of difficulty kind of sounds familiar, I think, if you check back on the developmental continuum for speech sounds. It is that same continuum. In other words, children, as they're developing speech, develop speech from easy to hard, and people with motor speech disorders drop off the hardest ones the first, and then they will retain the easier ones. So there's an example, and that's right from the Mayo Clinic test. Okay, then we have them do these repetitions, just one time each. And what's happening here is we're taking the same syllable, cat, you can see cat, 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 and adding other syllables to it. Dysarthrics will do relatively well with that, to the extent they can produce cat at all, or those sounds at all. There are some sounds that will be more difficult because of the particular pattern of weakness, oral weakness that they've got. But with an apraxia of speech, adding the syllables makes the first part hard for them too. So whereas they may have been able to produce cat in a CVC, you get the catastrophe, and now even the cat comes out wrong and showing those characteristics. So the more phonetically complex you make the word, the more they're going to start to show you the characteristics of the apraxia of speech. All right. Then here's the three repetition test I mentioned to you. These are multiple repetitions of the same word with increasing phonetic complexity, and they will apraxics will be able to get them on one iteration of the triad and maybe not the others. And they'll meanwhile be showing you the characteristics of apraxia of speech. Whereas if you just had them say animal once, if they're not too bad off, they may be able to get that and not show you any characteristics of apraxia of speech. But we're making it harder and making it more likely that they're going to show you the inconsistency factor that was such a hallmark of apraxia of speech. Some of the dysarthrias will be highly consistent across their three repetitions. Flaccid and spastic in particular will be quite consistent. They're just simply reflecting changes in their muscle strength and tone, and it doesn't change from one word to another. It will reflect their dysarthria, and the clarity and intelligibility of their speech will be reflected as a function of the phonetic complexity. In other words, you give them a three consonant blend, and whereas they may have been able to produce the S in isolation in the word cis, you put a T behind it, and now you've made it more phonetically difficult, and they may start to show you that the S is off too, but consistently so because of the phonetic environment. So this is a highly diagnostically significant approach, is to have them say the same word 3 times. All right, now then we get to something which is just, of course, longer and more phonetically complex, and that is the repetition of sentences. And we also do elicit speech using oral reading of sentences and paragraphs. Of course, you're listening to spontaneous speech, and I'll make a point on the last thing in just a second. We listen to their spontaneous speech. Why don't you just limit it to spontaneous speech? Well, because it's just harder to diagnose them if you listen to spontaneous speech. When you get really experienced, you probably can do a pretty good job of actually diagnosing them based upon their spontaneous speech, but it helps to break it down as I've described. Now, we also do assess oral praxis. When we're doing this, we're listening for apraxia of speech, which is, and I could say it in a different way, we're assessing speech praxis, which is the voluntary production of movements involved in speech. when you assess oral praxis, you're assessing the voluntary production of movements in non-speech activities. Here is a 2-slide sequence on assessing nonverbal speech. So this is just a little rating scale. This is a little rating scale that's used. And this is, I believe, not a part of the Mayo Clinic, but they test oral praxis, but not with this. And then these are the things that you could have them do to test their oral praxis. Oh, I guess it does come from the Mayo Clinic. Okay, so I take that back. Ask them to cough, click your tongue, blow, even something now. These are kind of complex for somebody who really has oral apraxia. Even opening your mouth imitatively, sticking out your tongue imitatively, retracting your lips imitatively. Those are assessments for oral praxis too. Note that it says here command and imitation. Keep in mind that many patients, and particularly if they do have a verbal apraxia, have a cerebral lesion on the dominant side. So they very likely have aphasia also. They may not be able to comprehend the commands. So they may be able to produce the movement, but not to command. So we need to be able to differentiate inability to carry out commands versus inability to make the movements voluntarily, which is what we're trying to test. So we need to include imitation as well. And keep in mind, when you're testing oral praxis, you're testing voluntary movements. So these are movements like if you say, open your mouth, they're movements that you have observed that the patient does produce spontaneously. In other words, they have the capacity with the musculature to open the mouth. But when you make it a voluntary, purposeful, intentional activity, and they then can't do it, that's a reflection of their oral apraxia. Not all patients who have verbal apraxia have oral apraxia. Some do. Those who have an oral apraxia will tend to have a much more severe verbal apraxia. It kind of makes sense because virtually every speech sound is more complex motorically than opening your mouth or pursing your lips or retracting your lips. They're all, or sticking out your tongue. Even something like phonating, just producing voice. What's so complex about that? You got to perfectly balance expiratory force and glottal resistance and the shape of the articulators. There's a lot going on there, and it's got to be perfectly balanced, or it won't come out with voice at all, or it won't be the right vowel that you're trying to get them to say. So even the simplest speech sound we can think of is far more complex than really any of these. These are complex because they might be unexpected, and if they have any kind of a comprehension problem, they may have great difficulty figuring out what you're trying to get them to do. Okay, that is it. That is probably the shortest lecture you have ever had in this course. And you can see it is a change in direction. And so we are going to just have you spend the extra time listening to those samples. And then in class, we're going to have observations. We'll have observations every week now, except for the final exam week. That will just be a final exam. All right, we'll see you later.